2012, the Institute of Medicine, now the National Academy of Medicine, published a report that should have been front page news everywhere. They estimated that the United States wastes $750 billion in healthcare spending every year. That was 2012 dollars. The number's grown since. Not fraud, waste. Unnecessary tests, duplicate imaging, medications prescribed for conditions they don't treat, procedures that carry real risks and don't improve outcomes, infections that could have been prevented, paperwork that consumes resources without producing care. The list is specific. The amounts are staggering. $750 billion in a country where millions of people can't afford their insulin. This episode is about what healthcare researchers call low-value care. Tests, treatments, and procedures that, for specific patients in specific situations, provide little to no clinical benefit and often cause harm. It's a phenomenon that crosses specialties, insurance types, and income levels. It's not a story about bad doctors. It's a story about a system that generates waste as a structural output, not an exception. Understanding it matters because it complicates the simple story we often tell about American healthcare, that the problem is just that people can't afford care. Part of the problem is also that we spend enormous resources on care that doesn't help anyone. Let's do a background. We'll define the categories of waste, because not all of it is the same problem with the same solution. The National Academy of Medicine's 2012 breakdown identified 6 categories: unnecessary services, procedures, tests, and treatments performed on patients who could not benefit, accounted for the single largest share, approximately $210 billion annually. Inefficiently delivered services, care that's clinically appropriate but done in a way that costs more than it needs to, added another $130 billion. Excess administrative complexity, billing, documentation, compliance, added $190 billion. Then there are prices that are too high. The gap between what the US pays for drugs, devices, and procedures compared to other wealthy nations, adding $105 billion. Missed prevention opportunities, conditions that progress because they weren't caught or managed earlier, another $55 billion. And fraud and abuse, which is real, but accounts for a smaller portion than most people assume, approximately $75 billion. These are 2012 estimates. A 2019 JAMA study updated the analysis and estimated total waste $760 billion to $935 billion annually, potentially a quarter to a third of all US healthcare spending. 1/4 to 1/3. While we're having arguments about who can afford coverage. And here's the question that sits underneath all of this. If we know this is happening, why is it so hard to stop? Why is it still a problem? Why can't we make it better? The United States spends somewhere between $760 billion and $935 billion on healthcare waste annually. Understanding why requires understanding the forces that generate it, and they're not what most people expect. Why do physicians order tests that they don't need to order? The simplest explanation, that physicians order tests because they don't know better, isn't well supported. Physicians know generally what the guidelines recommend. The gap between what evidence supports and what gets ordered is driven by something more complicated. Defensive medicine. Defensive medicine is a real and significant contributor. A survey published in Archives of Internal Medicine found that 91% of physicians reported practicing defensive medicine, ordering tests, referring to specialists, or performing procedures primarily to reduce liability risk rather than because they expected clinical benefit. American physicians operate in a liability environment that is genuinely different from their counterparts in other countries. And that environment, it shapes clinical behavior. We'll dedicate a full episode to this later in the series. Fee-for-service payment structure compounds the problem. In the dominant model of American healthcare, reimbursement, physicians and hospitals are paid a per service rendered, per test, per procedure, per visit amount. There's no financial incentive to order fewer tests. There's often a financial incentive to order more. This doesn't make physicians mercenary. It means the payment environment pushes in a specific direction, and humans respond to incentives subconsciously without intent. Patient expectations also play a role. That doesn't get discussed enough. Patients sometimes expect imaging for back pain that guidelines don't recommend. They sometimes push for antibiotics for viral infections that won't respond to them. A physician who declines may face dissatisfied patients, lower satisfaction scores, and a longer visit. The path of least resistance is often the test or the prescription. What does low-value care actually look like? The Choosing Wisely campaign, launched by the American Board of Internal Medicine Foundation in 2012, asked medical specialty societies to identify tests or procedures in their specialty that were often unnecessary and sometimes harmful. The list runs to hundreds of items and includes some very common practices. Imaging for uncomplicated low back pain in the first 6 weeks. Guidelines recommend against it for most patients, but it's widely performed. Annual EKGs, electrocardiograms for patients without symptoms or cardiac risk factors. Not recommended by evidence, widely ordered. Routine preoperative testing for low-risk surgical procedures. A huge body of evidence shows that these tests rarely change management, add cost and anxiety. PSA screening, the prostate-specific antigen blood test, in men who haven't been informed of the uncertainty around its benefits and harms. The U.S. Preventative Services Task Force guidance has evolved repeatedly as evidence has been contested. These aren't obscure edge cases. These are things done routinely in high volumes in practices across the country. And the clinical evidence supporting them in these specific contexts, weak. Waste isn't neutral, it causes harm. Here's the thing about low-value care that often gets missed. It's not neutral. It can cause harm. Unnecessary imaging carries radiation exposure. Unnecessary procedures carry anesthesia risk, infection risk, and complication risk. Antibiotics prescribed for viral infections contribute to antibiotic resistance, which is one of the most significant public health threats of our era. Incidental findings on imaging ordered for other reasons, small kidney lesions, lung nodules, thyroid abnormalities, trigger cascades of follow-up testing, anxiety, and sometimes invasive procedures for conditions that would never have caused a problem. And all of those things can cause complications or even death. The medical term for this is overdiagnosis, finding and treating conditions that would not have harmed the patient if left undetected. It's a genuine clinical harm even when the original intention was good. Here's the complication in this story. Reducing low-value care is harder than identifying it. Physicians who know that test is low value still order the tests because of liability, because of patient demand, because of reimbursement structure, because of time pressure, because the EHR makes ordering easy or even automatic. And conversations about evidence are difficult. And cutting waste without cutting value, without denying people care that would genuinely help them, requires a level of clinical nuance that blunt cost-cutting tools don't have. Prior authorization, for all its problems, was partially designed to reduce unnecessary care, but it also blocks necessary care. The challenge of distinguishing between the two at the individual patient level at scale is formidable. So what does actually work? The evidence on that is more encouraging than the problem might suggest. Somewhere between a quarter and a third of what the US spends on healthcare, hundreds of billions of dollars, almost $1 trillion, goes to care that doesn't help patients and frequently harms them. That's the scale. Now let's talk about what's actually being done and what you can do as a patient. So what actually reduces waste? The strongest evidence supports a few interventions. Audit and feedback. Showing physicians data about their own ordering patterns compared to their peers is associated with modest but real reductions in low-value ordering. Clinical decision support tools built into EHRs that prompt physicians before they order a test of uncertain value have shown reductions in some categories. Payment reform, moving away from pure fee-for-service towards bundled payments or value-based models, reduces some overuse incentives, although it creates its own complications and administrative burdens that physicians hate. None of these are magic. None produce dramatic single-year changes, but they're directional and they're consistent with what we understand about how clinical behavior actually changes. Slowly, through environmental design, incentive alignment, and peer accountability, not through lectures or guidelines alone. The Choosing Wisely campaign has had documented impact in specific areas, particularly in reducing preoperative testing, but its overall effect on healthcare spending has been modest. Identifying what not to do turns out to be the easier part. Getting systems and individuals to stop doing it, that's harder. What does this mean for patients? You are a participant in this. You're not the cause. The system generates this independently of your choices. But you can advocate for yourself in ways that matter. You don't need an antibiotic for a virus, and you can question if you are being given one. When a test or procedure is recommended, it is completely appropriate to ask what evidence supports it for your specific situation. Physicians who practice evidence-based medicine should welcome this question. The answers aren't always simple. Medicine involves uncertainty and clinical judgment, but the question is legitimate. The phrase, "What happens if we wait?" is one of the most evidence-aligned questions a patient can ask. Many medications don't actually work for the majority of people taking them. For many conditions, watchful waiting with clear parameters for follow-up is as supported by the evidence as immediate action, and sometimes, I would say most often, better. Asking doesn't mean refusing care. It means participating in a calibrated clinical decision. Some other questions worth asking. What evidence supports this test for my specific situation? Not evidence in general, but your age, your symptoms, your risk profile. What will we do differently based on the result? If the test result wouldn't change management, that's worth understanding, and the test probably shouldn't be done. What are the potential downsides of this test? Radiation, false positives, false negatives, incidental findings, downstream procedures. These are real, and your doctor should be able to articulate them. Is this a Choosing Wisely item for your specialty? Physicians familiar with the campaign will know what this means. It is a reasonable, respectful way to open a conversation about whether a test is evidence supported. In closing, the 30% problem is not a story about greed, although incentives do matter. It's not a story about incompetence. The physicians generating these tests are often skilled and well-intentioned. It's a story about a system that wasn't designed to optimize for patient benefit. It was designed to optimize for throughput, liability avoidance, and revenue, and increasingly patient satisfaction. And patients historically are more satisfied if they get something from the doctor. So changing all this requires changing the system. That's slow and political and difficult. But understanding it, knowing it exists, knowing what drives it is the first step towards asking better questions about your own care. In the next episode, we're going to learn about something that's connected to everything we've covered in this series so far. The cost problem, the authorization problem, the waste problem, and it doesn't get nearly enough attention. What happens when hospitals stop competing with each other? Over the past 2 decades, there's been a wave of consolidation in American healthcare. Independent practices absorbed, community hospitals acquired, and when competition disappears, prices tend to go up. Quality does not always follow. That's our next episode, hospital consolidation, and what it means for the communities that live inside those merged systems. Thanks for listening. It's Dr. Edwards.